Okay, it's 2 o'clock, so we'll kick off. 2 o'clock Sydney time. So welcome everybody to our first Spotlight on Stigma webinar for this year. We're very thankful that you're joining us. We also know that it's World Pride this week in Sydney, and the Human Rights Conference started today. So I know some people have registered so they can watch the recording of this later on. So shout out to you all. Wherever we are across Australia, we're on Aboriginal land. I'm on the land of the Bidjigal people of the Eora Nation. But behind me is an image I took on Sunday of a wabba, which is Lake Macquarie. And I've been spending a lot of time on Awabakal lands where I grew up. And I thank and recognise the traditional custodians of those beautiful lands and waters for their ongoing custodianship and the way that looking after those lands and waters for millennia. It's also important to note that Aboriginal and Torres Strait Islander people in Australia and Indigenous peoples around the world have experienced a disproportionate burden of HIV. And we can't forget that or leave any group behind, particularly when we're thinking about the intersections of HIV stigma and racism. So in our seminar today, we've got two amazing speakers that I'll briefly introduce, and then we'll get on to hearing from them, from their expert views. The ways that we have always run the Spotlight on Stigma is to ensure that we've got the voice of community front and centre. We can't be doing anything about stigma reduction without having voice of living experience right there. So that's the way we've organised this session today as well, of course. If you want to add questions or comments, please do so in the chat. We'll have some time for discussion later on, and I'll try and manage that as we go through so that our speakers have a way into what can be a really engaging chat in that chat function. So let me introduce our two speakers, Sarah Calabrese and Scott Harlum. Sarah's Associate Professor from George Washington University, but she's on Sydney time. She's visiting our Centre for Social Research and Health on a Fulbright Fellowship for a couple of months this year. So we're so appreciative of having Sarah and her expertise coming to us in person on land today. And Scott Harlum, lots of things to say about Scott, but as you can see in his tag beneath his mug there, current president of NAPWA and director of AFAO, and a long history of working in this space and in other areas of professional service too. So without any further ado, I'm going to hand over to Sarah to go through your presentation, and then we'll move on to Scott later on. So over to you, Sarah.
Great, thank you. Give me just one moment to share my screen. Okay, are you seeing my presentation okay?
Yes.
Okay, perfect. Great. Well, thank you for the introduction, Carla, and it's a pleasure to be here. I'm happy to be here on this call, but also happy to be here in Sydney and doing this fellowship. It's really an opportunity of a lifetime to get to be here and to work with Carla and Carla's team. So thank you very much for having me. I too would like to acknowledge the Bidjigal people, the traditional custodians of the land. I'd also like to acknowledge the elders, both past and present, and extend that acknowledgement to other Aboriginal and Torres Strait Islanders who are present here today. Give me just 1 second. I'm having a minor technical issue and I'll be right with you. Okay. So today I'm going to be presenting a survey study that I did with my team that is back in Washington, D.C. It was a national survey-based study with men who have sex with men. Before I get into the details of the study, I'm just going to give some basic background about U equals U and HIV stigma, just to ensure that everyone is kind of on the same page, although I'm sure a lot of people on this call are experts in both subjects. So in recent years, science has conclusively demonstrated that undetectable equals untransmittable. So that is, people who have sustained undetectable viral loads cannot sexually transmit the virus to their partners. And what you see there is just a summary table of some of the recent studies that have been fundamental in or foundational in establishing U equals U. And that last column on the right there, where you see all zeros, that shows the number of linked infections when a partner with HIV is stably virally suppressed, and that number is 0. So again, U equals U, I mean, major breakthrough, something that is incredibly important for a number of reasons. And this slide is really focusing on the U equals U campaign, which was launched in 2016. It's a major worldwide initiative to spread awareness about U equals U. And what you see on the slide are images taken from the campaign website. And you know, one of the major reasons that U equals U is considered to be important is because it has the potential to dismantle the HIV stigma that has been destroying the lives and impeding progress in the field since the beginning of the epidemic. So just to make sure we're all on the same page in terms of conceptualizing stigma, there's certainly been a number of different ways of defining stigma in the past. For today's study, I'll be defining it as social devaluation based on a distinguishing characteristic that maintains power hierarchies within society. And so by extension then, HIV stigma is social devaluation based on HIV status. So HIV stigma is you know, pervasive in both the US and Australia and worldwide, but to give you a sense of, you know, some of the numbers here in, or not here, but in the US, where what is usually here for me, nearly 9 out of 10 adults agree that there's still stigma around HIV. 17.5% of adults in the general public report being afraid to be around a person with HIV due to fear of infection. 12.5% agree that people who have HIV participated in illicit or immoral behavior. So you can get a sense of the really negative attitudes, even though they're not endorsed by the majority, it's still a significant minority, which is troubling. In Australia, these numbers and images come from Carla's team. So 50% of adults in the general public reported that they would behave negatively towards people living with HIV because of their HIV status. And among people who are living with HIV, over a third report experiencing stigma or discrimination related to their health over the past year. So those numbers are really just to demonstrate that HIV continues to be a pervasive problem. There are many firsthand accounts by people with HIV describing the destigmatizing impact that U equals U has had in their own lives. However, research on the association between U equals U and HIV stigma is fairly sparse. However, here you can see a couple of recent empirical studies that have investigated that association among MSM and specifically MSM in the US. So one which included over 30,000 US MSM with HIV suggested positive implications of U equals U for stigma. Another, which was done with HIV negative US MSM, examined both awareness and perceived accuracy of U equals U relative to perceived HIV stigma, failed to detect a significant association. So these early studies offer important preliminary insights, but we really need a more comprehensive understanding of how U equals U impacts multiple dimensions of HIV stigma among people with HIV, as well as people who are HIV negative. So the aims of the study I'll be sharing today were to examine associations between U equals U belief and multiple dimensions of HIV stigma among US MSM. And then there were a couple of exploratory objectives as well. One was to explore whether the association between U equals U and belief, U equals U belief and stigma varied according to HIV status. So for those who are familiar with some of the statistical technicalities, essentially looking at HIV status as a moderator. And then also to explore whether simple messaging could affect the associations. So looking at messaging as a moderator. And I'll talk a little bit more about what that simple messaging is in just a moment. As far as methods, so MSM were recruited to participate in this US-based online survey through dating apps and social media in 2019 and 2020. Primarily, we recruited through a dating app known as Hornet. We partnered with them on this study, but we also recruited through a few other apps and social media sites. Eligibility criteria were fairly liberal. The individuals needed to be able to read and answer questions in English, report being 18 or older, identify as a man or transgender man, and report having sex with men. So initially, participants were provided with information about the study online, consented online, and then were asked to report U equals U awareness and belief, and I'll give you more details about how we asked those questions in just a moment. After reporting that information, they were randomized to one of 3 different messaging conditions. And the first one was considered to be the no risk messaging condition, or essentially the U equals U message. And so they saw on their screen this message saying that antiretroviral therapy preserves the health of people living with HIV. When ART results in viral suppression defined as less than 200 copies per milliliter or undetectable levels, it completely prevents sexual HIV transmission. This means that people who take ART daily as prescribed and achieve and maintain an undetectable viral load have no risk of sexually transmitting the virus to an HIV negative partner. And we attributed the quote to the director of the Division of HIV/AIDS Prevention of the CDC. This actually was a message that was adapted from a letter written by the director. And here in orange, I've highlighted key pieces of information just to draw your attention to them, because you'll see that that changes across messaging conditions. They were not highlighted in the actual message that participants were presented with. The second message was considered to be low risk messaging. And so it's same message, except instead of saying that undetectable levels completely prevents sexual HIV transmission, we say it helps to prevent. Rather than saying no risk, we say low risk of sexually transmitting. And then in the third condition, risk was not mentioned. And so you can see instead, the first part of the message is the same, and then we just say that undetectable levels help keep people with HIV healthy. So again, no reference to risk. So as far as the specific measures, so prior to being presented with those different messages that I just shared, people reported their awareness of U equals U. That's how we asked the question, have you ever heard of U equals U? And then we asked them to report their belief in U equals U. And so the way we asked that question was not about the term U equals U itself, but rather the conceptual meaning of it. So we asked if someone with HIV has been virally suppressed, meaning has an undetectable viral load for 6 months or more, what do you think the risk of that person sexually transmitting the virus to an HIV negative partner is? You can see the response options below. And we dichotomized the responses so that if they said 0%, meaning they definitely would not sexually transmit, that was considered to be belief in U equals U. Anything else, so any perception of there being any level of risk other than 0% was considered to be disbelief. So after being presented with the messages that I showed earlier, they were then asked to complete measures of HIV stigma. And I have a list of the stigma measures here. I'm going to describe them in a little bit of depth, but I'm happy to provide more details after our discussion today if it would be helpful. So for those participants who had HIV, we asked about perceived societal HIV stigma. So questions were asked about what they thought most people thought. So an example item would be, most people think getting HIV is a punishment for bad behavior, or most people think less of someone because they have HIV. We asked about internalized stigma, which was really about what they think. So an example item would be, I think less of myself because I have HIV. We asked about experienced HIV stigma in terms of microaggressions. And so a sample would be, how often over the past month has someone assumed you don't or shouldn't have sex because of your HIV status? Or how often has someone's body language showed you that they were bothered because of your HIV status? And then enacted viral load stigma. And this was asked specifically with the subset of participants who reported having an undetectable viral load. We asked about enacted stigma against people with a detectable viral load. So how often over the past month, for example, you assume someone with a detectable viral load doesn't or shouldn't have sex because of their, detectable status. Among participants who were HIV negative or reported not knowing their status, we asked the same questions related to perceived societal HIV stigma. We asked them about personal stigma. So that what took the form of, as an example, I think getting HIV is a punishment for bad behavior, or I think less of someone because they have HIV. Feelings towards people with undetectable viral loads and towards people with detectable viral loads. So we gave participants instructions saying it's natural for people to feel more positively towards some groups of people than others. Please rate your general feelings about each of these groups. There was a whole list of different groups described, and embedded in that list was HIV positive people who are virally suppressed and therefore have undetectable levels of virus. And then we also embedded HIV positive people who are not virally suppressed, have detectable levels of virus. And so people rated their feelings from 1 extremely negative to 9 extremely positive. And then lastly, we also asked people who are HIV negative about enacting microaggressions related to HIV and viral load. Basically stigma that they had enacted towards people with HIV or enacted towards people who had detectable viral load levels. In addition to that, we asked about background characteristics. So that included age, race, ethnicity, and other sociodemographics. And then finally, as far as the analytic approach, so we calculated frequencies, means, and standard deviations to describe the sample, the variables of interest, and then conducted multivariable linear and logistic regressions in order to examine associations between U equals U belief in each of those different dimensions of stigma, as well as the moderation that we described, or that I described earlier. So the interactions between U equals U belief and HIV status and messaging condition. So as far as results, this slide gives you kind of a snapshot of our sample. So altogether, we had 457 participants, all identified as men or transgender men. They ranged in age from 18 to 83 with a mean age of 41. The majority of our participants were non-Hispanic white and identified as gay. Most had at least a bachelor's degree, and over half had an income above 50,000 US dollars. As far as U equals U awareness, the vast majority of our sample had reported having previously heard of undetectable equals untransmittable, or U equals U. And as far as belief, we found that about 41% believed in U equals U. So in other words, 41% said that there would be zero risk associated with somebody who's HIV positive and is undetectable having a sexual relationship or having a sexual encounter with somebody who's HIV negative, 41% believe. So as far as looking at belief between, comparing it between those who had HIV and those who were HIV negative, we found that a significantly higher proportion of participants with HIV were inclined to believe U equals U compared with those who are HIV negative, which is consistent with previous studies. Okay, these results are for the subsample of participants with HIV. For those who are interested in the stats, you can see them summarized in the table. For those who are less interested in the stats, the findings are summarized in that bottom bullet point. So essentially what we found is that in this particular group of participants with HIV, U equals U belief was not significantly associated with any of the 4 dimensions of stigma that we measured. And when we repeated the analyses, restricting the participants to only those who reported having undetectable viral load levels, we saw the same pattern of results. This is the results for participants who were HIV negative or did not know their status. And you can see that the significant findings are highlighted in yellow. As before, the stats are summarized in the table, but the take-home message is summarized in the bullet point below. So what we found is that U equals U belief was significantly associated with lower personal HIV stigma, lower enacted HIV stigma, more positive feelings toward people with undetectable viral loads, and that there was a marginal association with lower perceived societal HIV stigma and lower enacted viral load stigma. When it came to the exploratory analysis we did looking at HIV status and messaging as potential moderators, HIV status did not moderate the association between U equals U belief and the 2 forms of stigma that were measured among participants in both status groups. So in other words, the association between belief and stigma didn't vary depending on whether somebody was had HIV or did not. And we also found that U equals U messaging did not appear to moderate that association between U equals U belief and any of the dimensions of stigma we looked at. And we restricted the dimensions of stigma that we looked at to those that were attitudinal or affective. So in other words, had to do with what they thought or what they felt, given that this was a cross-sectional study and we couldn't look at behavioral aspects. So we couldn't look at behavioral outcomes. So in other words, messaging didn't really have an impact either. So just to summarize, although the vast majority of participants in our sample had heard of U equals U, many did not fully believe it, particularly those participants who are HIV negative or didn't know their status. This is consistent with other research that has documented a disconnect between U equals U awareness and belief. We did not find significant associations between U equals U belief, and any of the dimensions of stigma we looked at among participants with HIV. That being said, it was a fairly small sample. And so I think the association that we expected was between U equals U belief and internalized stigma. That was in the right direction. It just wasn't significant, and it's possible that if we had a larger sample, it may have been significant. We did, however, see a number of significant associations between U equals U belief and stigma among those participants who are HIV negative or status unknown. And the 2 exploratory moderators we looked at, HIV status and simple U equals U messaging, didn't significantly affect the association between U equals U belief and stigma. Just to acknowledge a few limitations. So it was a relatively small sample size, particularly the subsample who had HIV, which limits the generalizability of our findings and increases the likelihood of type 2 statistical error, so failing to detect an effect. The cross-sectional design of the study, meaning the fact that we collected our data all at once rather than over time, prohibits us from making inferences about causality. So although throughout this presentation, I've been talking about belief in U equals U as sort of a causal agent or impacting HIV stigma, we can't really say that based on the study design. And it's also possible that, you know, these two things, it's probably a bidirectional relationship such that people who have lower HIV stigma, they may be more open to believing in U equals U. And then all measures were self-report. And so as with other survey studies, subject to social desirability bias, meaning some of the participants may have understated their level of stigma, for example, because that was, they believe, the expectation of the researchers or society were to not have stigmatizing attitudes. So to conclude, interventions are needed to correct commonly held outdated misconceptions about HIV transmission risk. Awareness of U equals U does not appear to translate to belief in U equals U. There's kind of something in the middle that we need to intervene to make that happen. And so initiatives must reach not only people with HIV, but should also be directed at all of society. So including people who are HIV negative and status unknown in order to maximize the destigmatizing impact of U equals U. In concluding, I'd just like to acknowledge my co-investigators and the students on my research team who have been instrumental in this and other research. We had a small grant to fund participant compensation. I've also included my contact information there in the corner. So I welcome you to reach out if you have any questions, certainly ask them during today's session, but also feel free to follow up with me. So with that, thank you all for your attention. And I will turn it over to Scott. Back to Carla.
Yeah, I'm just going to jump in and say thank you, Sarah. Thank you also for walking that balance between giving some meat for people who are interested in research and then doing the translation for people who are less interested in that meat, the research vegetarians amongst us. Make a silly joke. And I just missed it. Have you published that paper?
No, working on writing it up now.
Work on writing it. Okay. I was just going to say, if you had, you could drop the link in the chat, but we'll look forward to it when it comes. But that finding of an overall 41% belief in U equals U is really quite challenging. And I think Scott's going to have a bit to say about that. So I'll hand over to Scott. Away you go.
Absolutely. Research vegetarian, Carla. That's that's a great term. I think it probably applies to me. Thank you. I too acknowledge the traditional owners. I'm currently on Gadigal land in Sydney, pay my respects to elders past and present. I also pledge my support for the Uluru Statement from the Heart and for the establishment of a First Nations voice in the Australian Constitution. In Sydney, surrounded by world pride, I also acknowledge with deep love and respect my LGBTIQ+ family. Before I go on, I should add there's a low-level language warning for a point in what I'm going to say. I'm going to start by pointing out that which will be very obvious to all in just a few seconds, and that's that I'm a research vegetarian. I am not a scientist or a researcher. I'm in awe of the brilliant and talented scientists and researchers with whom I get to interact, but I'm not one of them. I'm a person with HIV, a policymaker, an advocate, and as president of the National Association of People with HIV, one of the public faces of HIV in Australia. I take a keen interest in as an observer in the research of others, and occasionally I get to contribute my lived experience to that research, although that's often an experience of me kicking furiously beneath the surface to simply keep up, to simply understand the language and the concepts and to understand where I might contribute and what that contribution might be. So thank you, Sarah, for a wonderful and accessible presentation for all. I point out that I'm not a scientist because I'm going to start by using some very unscientific language. I'm going to talk about how something feels. I'm going to talk about a gut response before I talk more about the science, and hopefully demonstrate along the way how important the work of the likes of Sarah and NAPA's very dear friend Carla Treloar is to our understanding of stigma and to informing the design and delivery of effective interventions. It feels to me, at least, very much like the story of U equals U. HIV stigma and men who have sex with men should be a relatively straightforward one. Think of the history for a second. It wasn't that long ago that sex with another man carried the risk of death in 10 years or less. It carried the risk of a horrible death to opportunistic infections, seemingly designed to be the most debilitating, most disfiguring and cruelest they could be, and plenty paid that price. In the midst of that risk, and with a kick along here in Australia, thanks to our old mate, the Grim Reaper, stigma might have been understood as just a reasonable human reaction, an instinctive response to a perceived threat, the flip side of the same coin that saw us consciously embrace risk management through behavioural change, safe sex, and universal precautions. But if stigma is simply a response to risk and fear-based, it feels plausible enough that if you remove risk from the HIV equation, which is what U equals U comprehensively achieves, the result should be the erasure of HIV-associated risk, stigma. If only stigma were that straightforward. Reduce fear, reduce risk, reduce stigma, but of course it's not that straightforward. We're 40 plus years along in this epidemic and yet stigma persists. It's a multi-headed monster that hangs over us, negatively impacting in all manner of ways, including our efforts to test and treat for HIV, in complicating disclosure and our negotiation of lust and love, and on the quality of life of people with HIV. We poke and we prod the monster and we've made some gains, but we have a very long way to go and much work to do. We haven't had a broad-scale anti-stigma communications and media campaign in Australia, and there are those, including my own, amongst my own membership, NAPWA's own membership, who would argue that's what's needed. You hear discussion of a campaign on the scale of Grim Reaper, the thought process being that if one campaign can cause so much harm, then another campaign to match can undo that harm. It feels to the proponents of it that such a campaign would work, and they're frustrated they're not getting traction. But it's a one shot in the barrel idea, not limited to TV and radio, but across multi-channels and formats. It would be hugely expensive, requiring funds to be diverted from other important work, almost all the other important work. And if we are to make that kind of investment, we would need some kind of guarantee of return. But given our limited success over 40 years in tackling HIV stigma, we simply cannot know. It's here, of course, that the gut instincts and how things feel to the likes of me and to those proponents of a broad-scale campaign make way for the scientific rigour applied by Sarah, Carla, and their colleagues in the research community. To thank you again, Sarah, for your presentation today and for visiting Australia and collaborating with our experts and contributing your expertise. I understand you'll be involved in some, NAPWA will be involved in a project with you while you're here, and I thank you very much for that opportunity. There are certainly some positives to be taken from your research and reflected in the Australian research into HIV stigma amongst men who have sex with men. It's encouraging that for people with HIV, U equals U has brought about increased comfort in being able to talk about their status. And it's encouraging to hear that for HIV negative people who know about U equals U and who comprehend the science, that it has had a positive influence in some cases over stigma. But then there are those who have heard of U equals U but are not convinced. And there are others who don't trust the science. I mean, what the WTF? They don't trust the science. When somebody figures out what's going on there, could you please let me know? In relation to stigma amongst men who have sex with men, there are, of course, other challenges. Reaching into that population, into the harder to reach pockets, to educate and raise awareness of U equals U so it can get about doing its stigma busting job is a challenge. The messaging itself is tricky. Undetectable equals untransmittable. It hardly rolls off the tongue. What is a viral load and how can somebody with HIV not have HIV? I smell a rat. What are these poofters up to, trying to convince me to fuck raw when I know better? Language warning applies. You think I'm joking. There are plenty of examples of men who have sex with men being confronted with that type of exchange on hookup apps. They're still happening, often with devastating consequences for the receiver of those messages, their morale and sense of self-worth. That kind of exchange drives HIV positive and HIV negative men alike underground. It drives disconnection, isolation, disengagement from support and care. It drives counterproductive attitudes and behaviours much more effectively than any of our efforts to influence productive attitudes and behaviours. And that means we all lose. To try and drive home the point that stigma is complex, that after 40 years, our understanding of stigma remains poor, our capacity to respond effectively even poorer, and that the only way forward on stigma is to return to base principles. The only way forward is to throw out what we think we know, to question every assumption, and if acting to intervene, do not do so lightly. Understand what you are trying to achieve and how you are trying to achieve it, and to always, always observe the first rule, do no harm. I want to read for you some of the findings of research commissioned by NAPWA and undertaken by market research company Ipsos, for which we received a report back in November last year, so it's relatively recent. We commissioned Ipsos to inform us, for us, a potential campaign to address stigma towards people with HIV, and there were two audiences that we decided upon were of interest to us. Asian communities living outside the inner metro areas, and white men aged 18 to 30 living in suburban and regional areas. We chose these communities because we assumed they would be generally unaware of advances in HIV treatments. They may hold stigmatizing views of people with HIV, and they may hold homophobic, biphobic, and transphobic attitudes. It was a very expensive piece of research. We certainly could have chosen other groups as well. But I think for the purposes of what we were hoping to achieve in this research, it did the job. Ipsos ran online communities and with the chosen groups and undertook in-depth interviews. It's some of the specific comments I want to take us to that came out of the interviews and the group discussions. But to summarise the findings of the research first, it found knowledge of HIV prevention, treatment and transmission is low, which we expected. There is a lack of trust in current information, which reflects some of what you said, Sarah. Othering and distancing from people with HIV is significant. More subtle approaches to creating affinity with people with HIV are likely to be cognitively easier to engage with for these populations. Responsibility was a recurring theme. You'll get that from the quotes. And PrEP was interpreted negatively by many who viewed it as a potential enabler of behaviours that put people at risk of acquiring HIV. So to some of the direct quotes, even from these target groups, you might expect some empathy for people with HIV, and you might expect an anti-stigma campaign to leverage that empathy, right? Well, no. To quote the Asian community target group, people with HIV are irresponsible and lack self-control. They have little regard for their health and well-being. From another, I think it mainly affects the LGBTIQ+A+ communities, people who sleep around using no protection, and people raised in poverty. I think they are just more exposed to it due to their lifestyle choices. To quote the white male audience, I definitely believe it to be a higher risk among certain groups of people: gay community, early adulthood, drug users, promiscuous people, poor income earners. I think people who have essentially given up on life and self-medicate or love for the moment with no ramifications are more prone to be susceptible to HIV. From another, I know that gay people are more prone to HIV, and perhaps others that complete risky sexual behaviour. I guess these people are more at risk because they are doing unnatural things. I think not engaging in homosexual practices would be a good start. In direct response to statements put to them by the research team, in another section of the interviews, amongst the Asian target group, the statement, people with HIV deserve a fair go. So responses to that statement: at the end of the day, they are human. We make mistakes. We don't deserve lifelong prejudice and discrimination. But at the same time, I feel like in most cases, they probably had a role to play in them contracting the virus. Likewise, we might imagine development of an effective prevention PrEP would be a good news story all round. Again, I'm afraid that's not the case based on what we found. One quote from the Asian group: never teach sex education. I knew nothing about sex. It's more about using billboards teaching abstinence, more the tactic to scare you, said one in the Asian group. In response to the statement, people who are sexually active can now take a pill that prevents them from acquiring HIV. One respondent said, I really think people should just stop sleeping around without protection with multiple partners. It's just wrong. So it's saying I can take this pill and sleep around and not worry about contracting HIV off some person who failed to disclose to me. Doesn't make me feel very positive toward people with HIV at all. The researchers made some recommendations, and they too are revealing. They said, what messaging will best challenge stigmatizing behaviours and attitudes? And they said that their findings were to convey the impact their attitudes and behaviours are having on the mental health of people with HIV. Interesting, when you remove the impact from the health impacts of HIV alone and couched in terms of the mental health of people with HIV, there was a markedly different attitude, which was amongst the people, which was interesting. What should be avoided in messaging, as it's more likely to prompt further stigmatizing backlash, the perpetuation of stereotypes, the existence of PrEP, it's an all-round a bad idea, language that frames us versus them, e.g. allyship, a sense of being in this together, was found very clearly to be language that we just should not be using in anti-stigma campaigns. So thank you to Carla and Sarah for your ongoing work in helping us better understand stigma. There's a huge challenge still against us and in front of us, and with your assistance, hopefully one day we will get there.
Great, thanks, Scott. That market research was so illuminating and horrifying all at the same time. So, well done to the company for getting through it. I sort of wanted to bring, while people are thinking about their questions and heading over to the chat or putting up their hand, I wanted to bring together some of the things that you both mentioned, which, Sarah, you had a number of stigma measures that you used, and Scott, you talked about we have to know what we're doing. And I wonder, stigma is a complex thing, it's multifaceted, there's different ways to look at it, to measure it, to understand it. Sarah, even in choosing the variables that you did you have to cut out other sections of stigma that you were interested, for example, or did you focus in on particular things for certain reasons? Do you want to talk a bit more about that?
Yeah, I mean, we did include quite a variety of measures, and there were certainly others that we could have included as well. But, we wanted to essentially get at kind of cultural or perceived societal stigma. We wanted to get a sense of what people believe themselves, whether that was personal stigma or internalized stigma among people who had HIV. And then we also wanted to get at some of the behavioral aspects, so discrimination and enacted stigma, which is why we were asking those questions. And we really tried to hone in on microaggressions as opposed to some of like the bigger forms of discrimination, just based on kind of our recent work, which would suggest that those might be more prevalent. So yeah, I mean, I guess we were trying to capture a wide variety of dimensions of stigma. And we probably could have included other measures as well, but just those were a lot. And I think as is, I already have conflicting feelings about including measures like that, just because of like the message they can give participants. Like it's important to be measuring stigma and to be asking these questions, but then also to be exposing participants to that content feels like it could be further stigmatizing. So I guess that was also, something a line we were trying to walk.
Yeah, we've definitely had that feedback from our community partners, that particularly those internalized stigma things, I feel negative term because of my attribute, very difficult for people to front up to. I also, we haven't used a measure of body language before. I wrote that one down. That's an interesting one. Somebody's body language.
Yeah. Lisa Eaton, who's a researcher in the US, she just developed this scale of HIV microaggressions, and she was involved in this project and shared it. So we used that, and then we adapted it to also apply to viral load detectability, but use like similar items. But yeah, kind of getting at those more minor aspects.
Yeah. And Scott, when you walked into this work you did with Ipsos, and you imagined stigma, like what were you imagining, and what came back that was beyond your imagination or your original casting of what you were thinking about?
I think we probably expected the hiding that we got in the results, Carla, but I think we needed to see them. It really, it was an effort to honestly inform what we were doing around stigma, and to establish that kind of baseline that you know, we exist within our own communities, within our own bubbles in many ways, but stigma is a very broad beast. It's you know, it's coming from in various forms from various different places, and if we are to tackle it at a sort of a population level, we need to be really honest and with ourselves about where we're at and the way people feel about us with those of us with HIV. As I said when I spoke, you know, we needed to test the assumptions that we make around, you know, that PrEP's a good news story. That just seems a no-brainer to all of us that have anything to do with it. But you know, universally in the research, PrEP was associated with people being irresponsible and you know, free pass to be irresponsible and to take risk. And we know it's actually, you know, a very responsible risk-reducing thing for a person to do, to take PrEP. So it's a that's where we came from, Carla. It was we certainly acknowledged there was a lot more research we could have done within the project. It was a very, very expensive piece of work, and so we know, you know, there's criticism of the research. We know there are many other groups that we could have had a look at and got slight nuance, but yeah, it was an attempt to you know, to reset our baseline in some ways about the assumptions that we made about the stuff that we just kept doing and was having no impact.
Yeah, good one. So we've got some great postings in the chat from Anthony and from Natasha, referring to some blogs written by Nathan, who's on the call, and Natasha's interview about aging and LGBT and HIV. So great things to go and have a look at. So Dean, you were asking about in the Ipsos research that NAPWA was involved in, Asian is a very general description. So was there more information on specific communities that were engaged in that piece of work? Scott, are you able to comment on that?
Look, that they were, yeah, point taken, Dean, and that's what I think I just sort of tried to address. There were you know, there are many other communities that we could have targeted. It was Asian communities living outside metro areas. So look, I know that is broad, but you know, and white men aged 18 to 30, you know, they were two groups that were just chosen, again within the limitations of the project. But I don't think it changes. I don't think it changes the effect of the information that we got back. You know, it's not the purpose of the study was to really, you know, debunk our assumptions and to reset our baseline in that sense. So that's you know, I've used it because I thought it was interesting for the purposes of this conversation, but it's not intended for sort of further you know, further or sort of academic application in that sense. So yeah, there's a lot could be said about the groups that we chose, and a lot has been said about the groups that we chose, but the results still were illuminating.
And Scott, Curtis is just asking you to solve it. So
yeah, I saw that. Thanks, Curtis. Yeah, cheers. I'll
what would the ideal anti-stigma campaign look like for you? What would come on?
Look, I'm to be fair, I'm not designing it, Carla, and you, my friend, are part of that process. So perhaps you should be answering that question. Look, if I knew, yeah, I'd be more confident. You know, again, we needed to establish that just how much we didn't know, and. You know, I think that's been now clearly established. That there was, you know, those recommendations about the, you know, don't talk about PrEP, don't, you know, because again, this free card to poor behaviour stuff. Don't, you know, don't appeal to kind of, unless you're taking the mental health line. Don't appeal to a sense of empathy for people with HIV because it has the opposite effect. You know, that there are some assumptions in that there are some recommendations in there. There's more work to be done, but Curtis, look, you know, we're a long way at this point from establishing just what, you know. I think that there may and there probably will come a day where there's you know, medium term, I guess, where there is a broad scale campaign of a kind done. There's a lot of call for it amongst people and the community, and that call gets louder. So what that form takes, I'll be as interested to see as you are.
Okay, yes, we're all trying to work this out, I think, in our various ways. Sarah, here's a BT question from you, from Dean Murphy, about what's in the middle of the U=U belief and attitude measures. And Dean's asking, are there things like implicit attitudes towards people with HIV, or given it was a survey of gay and bisexual men, is it attitudes towards sex with HIV positive men? Here's a good juicy one for you.
Yeah, so I'm just reviewing the comment. So, you know, as far as the messaging intervention not working or not really having an effect, I don't think that necessarily means that no messaging would work. I think that just that particular intervention that we, you know, is a short message. It could be a matter of who it was delivered from, right? Like maybe they would be more responsive if the messaging was coming from a healthcare provider than a public health official. Maybe if it was coming from a peer, maybe the content of the message. I mean, I think that, you know, I think part of the resistance to like believing in U=U and implementing it in one's own life is because it runs counter to what we've been hearing from public health professionals and from doctors and from everyone else for, you know, years and years and years about, you know, the importance of condoms and protecting yourself, and like almost don't trust your partners has been the message that has been put out there. So, you know, we can't necessarily assume that people will immediately reverse course. So I guess I don't have a great answer in terms of like what the solution is, like what type of messaging might be more effective. I know that Carla's team, for example, has done some work about exposing members of the general public to I get different groups, but in particular, I'm thinking about with HIV, like people who have HIV, like brief testimonial videos, and that having an impact on some stigma attitudes, and that having somewhat of a lasting one. I think there was a 3-month follow-up, and it seemed to last 2. So an intervention like that may be effective, you know, having a message that's coming from a member of the community. But, you know, ultimately a shortcoming of the work that I've done and that I presented here is that it's quantitative, and we didn't have the opportunity to follow up and ask questions. I mean, Scott, the research you shared was fascinating, and like Carla said, the quotes were like fascinating and really disturbing. But yeah, unfortunately in this study, we didn't get to ask, hey, you know, you said you're aware of U=U, you don't seem to believe it. Like, what's going on? Can you please explain? How can we change your mind? Like that just wasn't part of the study. So maybe a good qualitative follow-up could help with that.
Yeah, I think there's something about asking questions about, should people with HIV, for example, have the same rights as everyone else, or, you know, get healthcare when they need it, right? There's the kinds of things that people can agree with. But when you get to the questions about sex with someone with HIV, I think that enters a different realm. And that's where I think we're going to get some differentiating of people willing to put on the tick or flick or on the online survey, no, I disagree with that, and expressing stigmatizing attitudes. So I think, you know, the kind of contact interventions we've done are not at that level of sex. It's about, you know, stigma impacts on my life and makes it hard, and you shouldn't be stigmatizing, but not to sex. I think Donatella's given us a nice comment there too about language literacy, and I think that applies both to the work you were talking about, Sarah, and Scott too, that if you went further into communities that don't have English language literacy, you're likely to find more negative opinions about people with HIV and U=U. So I think that's an interesting thing to test, but I think Donatella's got a good hypothesis there to explore. And Vic's talking about the way the messaging is delivered. I think that's what you were talking about, Sarah, about how it comes, who's presenting it, what format, and from peers as well, which you mentioned in your response. All of those things are, you know, subject to research, right? We can design different types of messages delivered by different people in different ways, combinations of all of that. And we just don't have that level of sharp, clear research to guide us in making choices about campaigns yet, because there is so much to potentially do here.
I'll just acknowledge, if I may break in there, Carla, that Vic is actually a peer worker. So you know, so Vic is exposed to you know, it's a great deal of experience, years of experience in, you know, positive experience where he no doubt has been able to impact in a positive way on people with HIV themselves. So yeah, as you just put, Carla, there's a lot of ways, a lot of means, a lot of avenues for you know, and audiences to be explored in it. And but I think even Vic, you'd have to agree that some of what came out of the Ipsos study was really does require us to look really closely at some of the stuff we've just do because we think it works, and you know, maybe at the extreme end, maybe contrary to that first rule, do no harm. You know, are we actually making things worse in some of what we do?
Great point. We're coming up to the end of our session, but Richard raising the issue of political leaders to endorse You Equals You and talk about why it's important, you know, that leadership from the top. And we do have a few of us were at an event last night for World Pride, and we had the Parliamentary Friends Group and the Assistant Minister for Health talking very positively about You Equals You and the rights of people with HIV. So we do have some purchase there, but what other types of people we can motivate or enact or mobilize around this important. And Curtis referring to a study of PrEP experienced gay and bisexual men about willingness to have sex. So Curtis, feel free to drop the link to that paper or report in the chat if you want. And Vic saying, bit surprised and not surprised by the low numbers. And yes, making those announcements outside of sector events about support for You Equals You. Totally agree, Richard.
Can I just say, Carla, about the political support? The government has endorsed the Agenda 2025 agenda, the blueprint for ending HIV transmission in Australia. Stigma is a major component of that. The HIV task force that's just been appointed, and one of its primary responsibilities will be enacting Agenda 2025. There is a very big acknowledged chunk of that work relates to stigma. So you know, there is some political will that is potentially a significant funding to flow from that. So we'll look forward to what comes from that.
I'm just trying to quickly pick up the link to Agenda 25 and pop it into the chat before we finish up. Any last comments from Sarah or from Scott before we wrap up?
I guess I just want to thank Scott. Thank you, Carla, but also thank Scott for this fascinating discussion and for sharing kind of your thoughts. And also you had mentioned that NAPWA is helping with my research. I wanted to extend my thanks to you and to NAPWA for helping with that. I'm looking forward to partnering.
Thank you, Sarah. Anything that any contribution to our collective knowledge of stigma, we are very thankful for, and thank you for coming.
Great. So Travis, yes, we're making a recording that'll be online. We'll send it around to everybody who registered, and you can send it on. Before we finish, I just want to thank Jane and Andrew from Pods Life New South Wales for my lovely t-shirt. Bring it with pride. Thank you.
Nap was mine, Carla.
Yes. Bring out all your t-shirts. We love them. So thank you very much. We'll have more on this series to come during 2023. Really appreciate you all coming and turning up. And you can send it on to people to watch online when the recording's available. Thank you, Sarah. Thank you, Scott, so much for being here. And thanks to Eleanor Karma and our team for putting this all together. And yep, few things coming into the chat. Thank you very much for sharing those, Dean. Okay, thanks everybody. Have a good rest of the day wherever you are.